Hello, everyone, and welcome to our module on pericardial disease. Let's start by talking about the structures that make up the pericardium, which is the connective tissue sac that surrounds the heart. And the pericardium is made up of a couple layers. So to understand this, let's look at this cartoon on the slide here. So just to orient you, imagine this is the left ventricular cavity filled with blood. Lining that cavity is a layer of cells called the endocardium. And then just beyond that are the muscle cells of the ventricle, and that's the myocardium. But then out here is where you find the pericardium. And so let's talk about what makes that up. So one of the layers of the pericardium is called the fibrous pericardium. This is the outermost layer. It's shown here as this red layer right here. And then inside of that, you have two layers, which are collectively called the serous pericardium. But actually, the serous pericardium has two parts to it, a parietal layer and a visceral layer. The parietal layer is what's shown in green right here. This part of the serous pericardium is stuck to the fibrous pericardium. Then there's a space called the pericardial space, and then you have the epicardium. And so the epicardial layer of the heart is actually part of the pericardium. It's the visceral layer of the pericardium. So you've got this visceral layer here, then you've got a space which is filled with pericardial fluid, then you have the green layer, which is the parietal layer, and then out beyond that you have the fibrous pericardium. The structures that make up the pericardium are innervated by the phrenic nerve, and you may know that the phrenic nerve arises from the cervical spine between C3 and C5. This layer of the cervical spine also has sensory information to the shoulder. So many patients who have pain related to pericardial disease, such as pericarditis, which we'll talk about in a minute, they will complain of pain that is referred to the shoulder, and they're sensing it here because of the phrenic nerve innervation of the pericardium. There are basically three pericardial diseases that you need to be aware of. The first is pericarditis, which is inflammation of the pericardial layers. The second is pericardial effusion or tamponade. This is what happens when this pericardial space gets overfilled with fluid. It always has some fluid in it, but if too much fluid builds up, that can lead to an effusion and tamponade. And then finally, constrictive pericarditis is a special condition where the pericardium has become calcified and stiff. And we'll talk about that at the end of this video. So we'll start with pericarditis, which is the most common pericardial disorder. As I just said, it refers to inflammation of the pericardium. It's an immune-mediated process, but the details of this are poorly understood. So you're not going to need to answer questions on your board exams about what antibodies or what cell types cause pericarditis, because we don't really understand that. All we know is that it's related to inflammation and the immune system. And as we'll talk about later, there are good treatments for pericarditis, but it can recur. So there are some patients who have recurrent episodes of pericarditis over the course of their lives. We don't really understand why this happens to some people and not to others. The symptom that patients usually complain of when they develop pericarditis is chest pain. Sometimes they can also have shoulder pain, like I mentioned before, because the pericardium is innervated by the phrenic nerve, but more often they simply have chest pain. It's classically described as a sharp pain, and this distinguishes it from the pressure-like chest pain that patients usually get when they have angina or myocardial infarction. And then the chest pain usually gets worse with a deep breath. Pain that does this is called pleuritic. And this happens because when you fill the rib cage with air, the pericardium tends to rub against structures. Pain also gets worse with lying flat or lying supine, and once again, it's because this position makes the pericardium rub against structures in the chest. And then patients will tell you they feel better when they sit up and lean forward, and that's because doing this sort of moves the pericardium away from neighboring structures in the chest. Because this is an inflammatory process, patients can have fever. They can also have an elevated white blood cell count, which is leukocytosis. And if you measure an erythrocyte sedimentation rate, that can also be elevated. All these things are just general features of the inflammation going on in the heart. This is a 12-lead EKG from a patient with pericarditis, and there are two classic EKG findings that you have to be aware of in patients who have pericarditis. The first one is diffuse ST elevation. So let's look at lead 2 right here. This is the baseline, and here is the ST segment. It is elevated. But if you look closely, you can also find ST elevation in some other leads. Here's lead V4. There's ST elevation there. I can see it in V2 right here as well. And if you look at this EKG, you can find evidence of ST elevation to some degree in the majority of the leads. So one of the classic findings of pericarditis is diffuse ST elevation. And again, this is different from myocardial infarction, where patients will have focal ST elevation just in certain leads. That's not the case in pericarditis. It's diffuse ST elevation involving multiple leads. And then I've zoomed in here on lead 2 so I can show you the second classic finding of pericarditis on EKG, and that is PR depression. So if we look over here, this is the start of the P wave, but then it finishes at a much lower point. sort of like it's going downward like this. That's PR depression. So PR depression, along with diffuse ST elevation, are the two classic EKG findings of pericarditis. Patients who develop pericarditis have their EKG go through a couple of stages as they recover from the acute episode. So technically, there are 4 stages of EKG changes. Stage 1 is the stage I was just talking about. That's when patients have chest pain, they have diffuse ST elevations, and PR depressions. As patients start to get better, about a week later, their EKG becomes normal. But then a little bit after that, they can develop T-wave inversions, and then finally, it will go back to normal and stay normal. On physical exam in pericarditis, when you listen to the patient's heart, there's a classic finding called a pericardial friction rub. It's a scratchy sound, often described like sandpaper rubbing together, and it's present throughout the cardiac cycle in both systole and diastole. And I'll play you an example of what that sounds like now. There are a number of potential causes of pericarditis. The most common cause is idiopathic. Most patients who present with this condition, we don't really know why they developed it in the first place. It also commonly occurs after a viral illness. Many viruses can trigger an acute case of pericarditis. The classic viral cause is Coxsackie virus. And classically, the pericarditis will follow a viral upper respiratory infection. So the patient will tell you that they had a runny nose or a sore throat a week or so ago, and now they have symptoms of pericarditis. That's a classic history of a viral case of pericarditis. It's uncommon, but bacteria can cause pericarditis. Some patients who have pneumonia will have spread of the bacterial infection in their lungs to the pericardium. Also, after surgery, if bacteria get introduced into the chest, that can lead to pericarditis. And then finally, in parts of the world where tuberculosis is common, patients can develop pericarditis from tuberculosis. There are also rare reports of fungal cases as well. Pericarditis is a classic feature of uremia, meaning acute renal failure. So patients who come in with acutely elevated BUN and creatinine and renal failure, they often have pericarditis. And when they receive dialysis or their kidney function gets back to normal, the pericarditis usually goes away. There are 2 forms of pericarditis that can occur after a myocardial infarction. I talk about these in the videos on coronary artery disease, but fibrinous pericarditis is a form of pericarditis that occurs a few days after myocardial infarction. Basically, the ischemic tissue that's inflamed and damaged, that process spreads to the pericardium, causing pericarditis. The second type of post-myocardial infarction pericarditis is called Dressler syndrome. This occurs weeks after a myocardial infarction. We don't know what causes it, but it's an autoimmune process. And then finally, many autoimmune diseases like rheumatoid arthritis and lupus are associated with pericarditis. So patients who have these conditions can also have bouts of pericarditis. The treatment for pericarditis is with anti-inflammatory drugs. So NSAIDs can be used, drugs like ibuprofen and naproxen. Steroids can also be used. And then finally, colchicine, which is a special anti-inflammatory drug, is often used in pericarditis. This drug inhibits white blood cell function by a complex mechanism. We don't really completely understand how colchicine works, but it has basically 3 niche uses that you should know about. First one is in gout, which I talk about in videos in the musculoskeletal section. It also works in a rare condition called familial Mediterranean fever. And then finally, it's often used in pericarditis. It's added to NSAIDs, and the 2 are used as dual therapy. And there have been studies that have shown when you treat patients with pericarditis with NSAIDs and colchicine combined, there's a lower risk of recurrence of pericarditis. Some patients who have pericarditis also develop myocarditis. Myocarditis means inflammation of the myocardium. And when patients have pericarditis together with myocarditis, we call this condition myopericarditis. And remember, the pericardium sits right on top of the myocardium. So naturally, some cases of pericarditis, the inflammation will spread to the myocardium. When this happens, the patient's clinical presentation can be similar to that of ischemia because you have inflammation in the myocardium just like you do with a myocardial infarction. So patients can have chest pain, EKG changes, their CKMB can go up, their troponin can go up. All this will look like a myocardial infarction, but if you image the coronary arteries, there's no obstruction to blood flow. And that's how you know the patient has myocarditis, not a myocardial infarction. And once again, if they have that together with clinical features of pericarditis, we call that myopericarditis. Okay, now let's move on to our second pericardial disease process we're going to talk about in this video, and that is pericardial effusion. So if you look at this echocardiogram image on the left side of the screen, this is the left ventricular cavity right here, and this is the left ventricle muscle right here. And you can see this black space outside the left ventricular wall. That's evidence of a pericardial effusion. There's always a little bit of fluid in the pericardial cavity, but there shouldn't be this much. And so when the amount of fluid builds up like this, we call that a pericardial effusion. And it's usually diagnosed by echocardiogram because you can see this black rim of fluid surrounding the heart. There's also a classic finding on chest x-ray and pericardial effusion. That's called a water bottle sign. And that's what you see in this picture here. Basically, the heart just looks large and round, sort of like a water bottle, hence the water bottle sign. So as I just said, pericardial effusion refers to the accumulation of excess pericardial fluid in the pericardial space. And the reason this is bad is because that accumulation of fluid can lead to high pericardial pressure, meaning a high pressure in the pericardial space surrounding the heart. And when this happens, the patient can develop pericardial tamponade. Tamponade means that not only is there an effusion present, but the pressure in that effusion fluid has gotten so high it's compressing the cardiac chambers. This can restrict the filling of the cardiac chambers, and that can lead to shock, which we'll talk about in a minute. And so pericardial tamponade is the feared complication of any pericardial effusion. Just so you know, it turns out the amount of fluid required to cause tamponade is variable. So if someone has an acute development of a pericardial effusion from bleeding, for example, after a motor vehicle accident, just a small amount of fluid can lead to very high pressure in the pericardial sac, causing there to be tamponade. On the other hand, patients who have cancer metastases to the pericardium, they slowly and chronically accumulate fluid. And these patients can accumulate a large amount of fluid before they get tamponade. And that's because their pericardium slowly stretches and accommodates the fluid so that you don't develop tamponade until there's a very, very large effusion. So pericardial tamponade is a form of obstructive shock, and I talk about it in the video on shock. But what's happening is because you have this high pressure fluid surrounding the heart, there's impaired filling of the right ventricle and the left ventricle. And when these chambers underfill, there's going to be low cardiac output, and that's what leads to shock. So to understand this, let's imagine that this is the left ventricle right here, and it can receive blood from the left atrium. Well, remember, the left ventricle is going to fill with blood from the left atrium until the pressure in the left ventricle gets high enough to close the mitral valve located right here. Well, now let's imagine while this filling is going on, we have a high pressure fluid accumulation pressing on the walls of the left ventricle. It's almost like someone is squeezing the left ventricle in their hand as it's trying to fill. Well, what this means is that it's only going to allow a small amount of left atrial blood to flow in before the pressure gets high and closes the left ventricle to more blood flow. In other words, closes the mitral valve. So all this fluid surrounding the left ventricle causes two things to happen. One is decreased filling of the left ventricle. Okay, there's less filling because there's pressure surrounding it in the pericardial space, causing the pressure inside the chamber to rise quickly. The other thing that's going to happen is the pressure in the left ventricle just overall during diastole is going to be high. So we're going to have high left ventricular end diastolic pressure, and that's because the blood in the left ventricle is being squeezed from the outside by the pericardial effusion. So back to this slide, because we're underfilling the left ventricle, we have low cardiac output. This leads to low blood pressure, and the sympathetic nervous system responds by causing vasoconstriction of arterioles, and so you get a high systemic vascular resistance in patients with tamponade. As I just showed you in my little drawing, there will be high right ventricular and left ventricular end diastolic pressure, and that's because those chambers are being squeezed by the fluid surrounding them. And when these pressures go up, you will also get high pressure in the atrial chambers. So the right atrial pressure will be high, and the left atrial pressure, which is a surrogate of the pulmonary capillary wedge pressure, these pressures will be high as well. And so I've summarized this information here on the slide. This is what you want to know. The pericardial tamponade for step 1. These are the kind of things they're going to ask you. Make sure you understand the reasoning behind all the items listed on this table. And then finally, when you drain the fluid from around the heart, you take away that constriction of the ventricles. That improves the cardiac output and it lowers the pressures in the chambers. So what are some of the causes of pericardial effusion and tamponade? Well, I mentioned this earlier, but patients who have cancer can have metastases to the pericardium, and this can cause fluid to leak into the pericardial space, and over time that can lead to large effusions and potentially tamponade. I told you earlier that uremia can cause pericarditis, and anything that can cause pericarditis can actually lead to an effusion or tamponade. About half of cases of pericarditis also have an effusion present, so anything that can cause pericarditis, like uremia or any of the other causes of pericarditis I listed before, those things can also cause effusions and tamponade. And then finally, trauma can lead to traumatic pericardial effusions. These come on suddenly, and like I told you before, in those situations, it does not take a lot of fluid for tamponade to occur. What are some of the clinical features of tamponade? Well, first of all, distant heart sounds are a clinical feature of anyone with an effusion, whether or not they've progressed to tamponade. Basically, it's hard to hear the heart sounds when the heart is surrounded by a large collection of fluid. And then dyspnea is a symptom of high left atrial pressure. We talked before about how the pressure goes up in the chambers in the heart, and when the left atrial pressure gets high, that can drive fluid out into lung tissue, causing pulmonary edema and dyspnea. And then finally, elevated jugular venous pressure is something you see whenever the right atrial pressure gets high. And I told you earlier how patients with tamponade will have high right atrial pressure. You'll read in your textbooks about Beck's triad. Beck's triad refers to distant heart sounds, elevated jugular venous pressure, and hypotension. This is what you can see in pericardial tamponade, and it's usually seen only in rapidly developing traumatic effusions. So these patients have the sudden accumulation of fluid in the pericardial space. This severely impairs LV function because the pericardium doesn't have time to stretch and accommodate the fluid, and that leads to tamponade and low cardiac output. In the slower effusions, like the kinds that you see in cancer patients, the pericardium stretches and dilates, so it's less common to see hypotension in patients who have large effusions in that situation. There are some findings on echocardiogram you can see in pericardial tamponade, so let's talk about that now. So first of all, in patients with tamponade, you can identify the effusion by echocardiogram. This is the pericardial effusion here in this image on the screen. It's this black space here. You can also see it here. It's surrounding the left ventricle, which is right here, and the right ventricle, which is here. But beyond simply seeing the effusion, there are other findings on echocardiogram that are often present in patients who have tamponade. One of these is chamber collapse. So in the right ventricle during diastole, when the pressure gets low, and also in the right atrium, if the pressure is high in the pericardial space from all that fluid, these chambers will collapse, and you can visualize that on echocardiogram. And then the other finding is called IVC plethora. This is just a fancy term, which basically means that the IVC is dilated and the size doesn't change much with respiration. So this is a finding you can get anytime there's very high pressure in the venous system, which includes in patients who have tamponade. So IVC plethora and chamber collapse are the two findings beyond identification of a pericardial effusion that are helpful on echocardiogram to diagnose tamponade. There is a classic physical exam finding seen in patients who have tamponade, and that's called pulsus paradoxus. So let's talk about that now. So during normal quiet breathing, when you inspire air, your systolic blood pressure always falls a little bit. This is a normal finding. We all have this. But in patients who have pericardial tamponade, that fall will be exaggerated. And by this, I mean more than 10 millimeters of mercury. If the systolic pressure falls by more than 10 millimeters of mercury on inspiration, that is called pulsus paradoxus. And it gets its name because in the old days, when there were no treatment for pericardial effusions and tamponade, the fall in blood pressure would become so severe that on inspiration, the patient's pulse would disappear. And so that's how it got the name pulsus paradoxus. To understand the physiology of why pulsus paradoxus occurs, let's look at what I've drawn on the right side of the screen here. So whenever you inspire or you take in a breath of air, you slightly increase the venous return to the right side of the heart. More blood flows into the right atrium and into the right ventricle. This will slightly increase the right ventricular size. Now, normally that doesn't cause much of a problem, but remember in tamponade, the right ventricular wall cannot expand outward because of the fluid surrounding it. So let's imagine we have a right ventricle here, and you take in a breath of air, and this draws in some blood from the venous system and the right atrium into the right ventricle. Well, normally this wall would bulge outward a little bit, but in a person who has tamponade, that can't happen because there's fluid surrounding the heart and there's high pressure here. So this wall can't move outward. So what happens then is the septum between the right ventricle and the left ventricle will bulge in this direction over towards the left ventricle because that's the only way it can go, since the effusion is keeping the right ventricle from bulging in the other direction. This is going to cause the left ventricular cavity to slightly decrease in size when the patient takes in a breath of air. And because it decreases in size, it fills less and there's less stroke volume and the cardiac output goes down, and that's why the blood pressure falls in patients who have tamponade. And so I've summarized these findings here. The septum bulges from the right side into the left side in patients who have tamponade. This shrinks the size of the left ventricular cavity. It fills with less blood and pumps less blood out, and therefore the cardiac output falls, and so does the blood pressure. And so this finding, a fall in blood pressure of more than 10 millimeters on inspiration, is called pulsus paradoxus, classic physical exam finding of pericardial tamponade. You can also see a pulsus paradoxus in patients who have severe asthma and COPD, but it's for a totally different reason than why the pulsus happens in patients with tamponade. In asthma and COPD, the reason the pulsus paradoxus occurs has to do with pulmonary pressure. So normally, when you inspire or draw in a breath of air, you slightly decrease the flow through the left side of the heart, meaning through the left atrium and the left ventricle. And this happens because of changes in the pulmonary pressures that occur when you inspire. Well, in patients who have lung disease, these changes are exaggerated. So normally, the pressures in your lung might vary from 0 to -5 as you inspire, but that change can be much higher. It can be as much as 40 milligrams difference between when you begin and finish inspiring in a patient who has lung disease. And it's this large change in pulmonary pressures that causes a large drop in blood flow to the left side of the heart, and that's what creates the pulsus paradoxus in asthma and COPD. There are some EKG changes you can see when patients have a pericardial effusion and tamponade, so let's talk about those now. So first of all, patients who have tamponade will have sinus tachycardia. This is because their left atrial pressure is high and it's difficult to oxygenate the blood. They usually feel short of breath, and so they often have sinus tachycardia. The other finding is that their EKG will have low voltage. This is because of the effusion. So what do I mean by this? Well, let's imagine this is a normal QRS complex that is this size. Well, in a patient who has a large pericardial effusion, the QRS complex will be much smaller. This is called low voltage because the QRS complex is not creating much voltage, and that's because it's hard for the EKG leads to pick up the voltage through the fluid surrounding the heart. So low voltage is another classic EKG finding you can see in pericardial effusion. And then finally, another finding you can potentially see is called electrical alternans. That's what's shown on this EKG on the screen. So look at this QRS complex and notice its size. It's about one big box in height. Notice this next one is only about half the size of the first one. And then this one is big again, and then this one is small again. And then we have big, and then we have small. This is called electrical alternans. It's when the QRS complexes are changing beat to beat in size. And this is what you can see in a patient who has a pericardial effusion when the heart is swinging in the fluid. Basically, as the heart beats, it moves back and forth. And this causes some of the QRS complexes to be large when the heart depolarizes close to the EKG lead, and other QRS complexes to be small when the heart depolarizes away from the EKG lead. In the video on venous pressure tracings, I talk about this pressure tracing right here. This shows the pressure fluctuation in the right atrium and the venous system as a whole as the heart moves through the cardiac cycle. And in that video on venous pressure tracings, I talk about the A wave and the V wave and what they mean and what causes them. Well, in pericardial tamponade, there are two classic findings that are abnormal that occur in the venous pressure tracing. The first one is called a prominent X descent. The second one is called a blunted Y descent. And let's talk about why those happen now. So this is the X descent right here in the normal venous pressure tracing, and it occurs because the right atrium is relaxing, the walls are moving outward, and that causes the pressure to start to come down. That's why this is called the X descent. What happens in patients with tamponade is the X descent becomes much more prominent and deeper, like what I've shown right here. The reason this happens is because there's a much bigger drop compared to normal in the right atrial pressure as the right atrium relaxes, and this is caused by the right ventricle contracting in systole. So to understand this, let's imagine we have the right ventricle here, and we've got the tricuspid valve here, and then above the tricuspid valve, we have the right atrium. Well, in a patient who has pericardial tamponade, there's all this fluid surrounding both of these chambers, and there's high pressure in the fluid in the pericardial space. Well, when the right ventricle contracts, these walls are going to move inward. This is going to allow some of this fluid up here to shift downward away from the right atrium on both sides. What's going to happen then is the right atrium is going to relax very vigorously. The walls are going to bounce outward much more quickly and rapidly than normal, and the pressure in the right atrium is going to drop a lot faster and a lot deeper compared to normal. And this is what creates the X descent in patients with tamponade. And so that's this finding that I've shown right here. It's called a prominent X descent. The other finding is called a blunted Y descent. This happens because it's hard for the right ventricle to fill in diastole. So this Y descent, which is this part right here in the venous pressure tracing, this fall in pressure right here, is caused because the right ventricle is filling with blood. Blood is leaving the right atrium, and therefore the pressure up here, which is the pressure in the right atrium, is falling. Well, that fall is going to be blunted in patients who have tamponade because the right ventricle is surrounded by high pressure fluid and it can't fill normally. And so these two findings, prominent X descent and blunted Y descent, are the two venous pressure tracing findings you want to remember for pericardial tamponade. And then there's one other finding that is classically seen in tamponade, and let's talk about that now. It's called equalization of diastolic pressures. This is a finding you can see if you obtain intracardiac pressure measurements, meaning measurements of the pressures in the left atrium and the right atrium and the left ventricle and the right ventricle. To do this, you have to insert a Swan-Ganz catheter, and I talk about Swan-Ganz catheters in the video on shock. So you can get equalization of diastolic pressures in tamponade. You can get it anytime the cardiac chambers can't relax normally. When that happens, the right atrial pressure, the left atrial pressure, the right ventricular end diastolic pressure, and the left ventricular end diastolic pressure can all become equal. And you will see this in tamponade. You can also see it in pericardial constriction, which we're going to talk about in a minute. So to understand this finding, let's look at the bottom of the screen. So here in this column here are the normal pressures you'd expect for the right atrium, the right ventricle, and the pulmonary capillary wedge pressure. Over here is what you might see in tamponade. So first of all, notice that the pressures are high. 20 is much higher than 5. 20 here is much higher than 10. We have high pressures, and that's because this patient's heart is surrounded by fluid, and the fluid exerts a high pressure on the chambers of the heart, and all the pressures go up. But notice also that the right atrial pressure is equal to the right ventricular diastolic pressure, which is equal to the pulmonary capillary wedge pressure. You normally do not see all three of these pressures being equal. This is something that only happens when the chambers cannot relax, and you see it in these two conditions here. So to understand this, let's once again imagine that we have a right atrium here, and then we've got the tricuspid valve, and then we've got the right ventricle here down at the bottom. And both of these chambers are surrounded by fluid. And let's say that the pressure in the pericardial space is 20. That's very high, and that's because there's so much fluid built up in that space. Well, what this means is the right atrial pressure can never get below 20 because if it tries to go below that, the chamber will collapse. So you're going to get a pressure of 20 at the lowest value in the right atrium, and the lowest value you're going to get in the right ventricle is also 20. The lowest values for pressure that can occur in these chambers is being dictated by the pericardial space. And so this is what happens in pericardial tamponade, and this is why you get that equalization of pressures, that classic finding of tamponade that you can also see in constriction. All right, so that's a nice segue into constrictive pericarditis, which is the final pericardial disease we're going to talk about in this video. Constrictive pericarditis occurs when there's recurrent or long-standing inflammation in the pericardium, and the pericardium eventually becomes stiff and calcified. At this point, it's like the heart is surrounded by bone, and the chambers can't relax because the pericardium is so stiff and calcified. This is a CT scan here on the left side of a patient with constrictive pericarditis. This white stripe here is the pericardium, and you can see that it has calcium in it. This is the left ventricle right here. We've got the right ventricle over here, and these chambers are surrounded by this white calcified material. There's also another image of constrictive pericarditis on the right. This is from an MRI. With MRI, depending on which sequence you use, the calcium will appear black, and you can see this black stripe surrounding the heart chambers. That's evidence of constrictive pericarditis. So as I said, in constrictive pericarditis, fibrous calcified scar tissue forms in the pericardium. This causes a loss of elasticity. The pericardium becomes stiff and thickened and sticky, and this can result from many pericardial processes. So this can occur in patients who have recurrent pericarditis. It occurs in some patients who have chest radiation for malignancy. It can occur in patients who've had heart surgery, who have had incisions made into their pericardium. And then finally, worldwide, especially in places where there's lots of tuberculosis, people can have pericarditis from tuberculosis, and that can lead to constrictive pericarditis. Let's talk about some of the other clinical features of pericarditis. First of all, you should know that pulsus paradoxus is uncommon. It only occurs in about 20% of patients with constrictive pericarditis. So on a step one question, if they describe pulsus paradoxus, they are almost certainly talking about tamponade and not constrictive pericarditis. All the pressures in the chambers go up, like the right atrial pressure, the end diastolic pressure in the ventricles, the wedge pressure, and this is because these chambers are surrounded and constricted by that fibrous pericardium. You get equalization of pressures in constrictive pericarditis, just like in tamponade, which we talked about earlier. And then in constrictive pericarditis, it's hard for the ventricle to fill, so the end diastolic volume is going to go down. It's high yield to know this little piece of physiology about constrictive pericarditis for step one. And that fall in end diastolic volume is a fall in preload, and that slightly decreases the cardiac output. And so I've summarized these findings on the bottom of the slide here. These are the physiology things about constrictive pericarditis you want to know for your board exams. And then finally, there can be a heart sound in diastole called a pericardial knock. It occurs shortly after S2. It can sound similar to an S3, and it's very hard to distinguish it from an S3. They're not going to ask you to do that on your board exams. Just know that this early diastolic sound after the second heart sound, called a pericardial knock, can be found in constrictive pericarditis. The main clinical complaint of patients with constrictive pericarditis is dyspnea, and this is because their left atrial pressure is high and there can be fluid in the lungs. The other thing to know about constriction is that there is very prominent right heart failure. So these patients present with markedly elevated jugular venous pressure, they have lower extremity edema, their liver can become very congested from this prominent right heart failure, and this sometimes leads to cirrhosis if the constriction isn't identified and treated. When this happens, the liver is described as a nutmeg liver, and that's because it starts to look like a nutmeg from being soaked with fluid for so long from right heart failure. There's a classic physical exam finding of constrictive pericarditis called Kussmaul's sign, so let's talk about that now. So I mentioned earlier how during normal, quiet breathing, when you inspire or draw in a breath of air, there's a slight increase to the venous return to the heart. This leads to a slight fall in the mean jugular venous pressure because blood is leaving the venous system and going into the ventricles and the heart. And in the videos on heart failure, I talk about how you can place the patient in this position and look at the neck veins to measure or estimate the jugular venous pressure. And so in a patient who does not have constrictive pericarditis, you should see that jugular venous pressure in the neck go down slightly when the patient takes in a breath of air. Kussmaul's sign refers to the opposite finding. The jugular venous pressure goes up with inspiration. This is abnormal. This is the opposite of what should happen. And this occurs anytime the right ventricle cannot accept the increase in venous return that occurs with inspiration. So instead of more blood going into the right ventricle, that blood goes into the right atrium and the pressure shoots up when the patient inspires a breath of air. You can see this in constrictive pericarditis. You can also see it in restrictive cardiomyopathy, which I talk about in another video. You can also see it in patients who have a right ventricular myocardial infarction. Their right ventricle is stunned and ischemic and it's stiff and it can't accept the increase in venous return. Importantly, though, you do not see Kussmaul's sign in tamponade, and it's important to remember this. So in tamponade, the ventricle can accept the increase in venous return, so you don't get this finding. So let me pause here and summarize the important points to remember about pulsus paradoxus and Kussmaul's sign, because both of these physical exam findings occur in pericardial disease, and it's very easy to confuse them as a medical student. So you want to remember that pulsus paradoxus is a classic sign of tamponade. The majority of patients with tamponade will have a pulsus, whereas it's much less common in patients who have constrictive pericarditis. Kussmaul's sign, on the other hand, is a classic sign of constriction. It's also seen in restrictive heart disease, and some people remember the mnemonic Kussmaul's in constriction restriction. And then at the bottom of the slide here, I've summarized these findings. This is what you want to know going into your step 1 exam. Remember that constrictive pericarditis and restrictive cardiomyopathy share a lot of physiology. In both conditions, the ventricular walls can't relax normally. And so that's why in both of these conditions, you usually don't get a pulsus, but you do get Kussmaul's sign. Tamponade is the opposite. In tamponade, that's when you should see a pulsus, but it's uncommon to see Kussmaul's sign. We talked earlier about how in pericardial tamponade, there are classic findings on the venous pressure tracing. Well, it turns out there are also classic findings associated with constrictive pericarditis. So let's talk about those now. So once again, this is a normal venous pressure tracing at the top of the slide here. It's got the 3 waves, the A, the C, and the V wave. This is the X descent right here, and this is the Y descent right here. And this is depicting the fluctuation in pressure in the venous system or the right atrium as the heart moves through the cardiac cycle. And earlier we talked about how in pericardial tamponade, this Y descent, this falling in pressure after the peak of the V wave, is flattened or less prominent in tamponade. Well, the opposite finding occurs in constrictive pericarditis. The Y descent is rapid and prominent. It looks like what I've shown right here. In order to understand why this happens, let's imagine we've got a right ventricular chamber here, and it's got this sticky, fibrous, calcified pericardium attached to it. And remember that the right atrium is what will fill the right ventricle with blood in diastole. So in systole, the walls of the right ventricle are going to come inward to squeeze the blood, but they're going to drag this sticky, calcified pericardium with the walls as they move inward. When the right ventricle stops contracting and relaxes, what happens is the walls snap backwards, because they're attached to this sticky, calcified pericardium. That's going to cause the pressure in the right atrium to drop because blood's going to be sucked in. So what you're going to see on the venous pressure tracing is a rapid, deep fall in the pressure. That's that Y descent. However, once the right ventricular walls reach the point where the pericardium is at its baseline, then they're going to be blocked by this stiff pericardium. And so this fall in pressure is going to stop and the pressure is going to rapidly go right back up. So this is the rapid Y descent, and it occurs because blood is sucked into the right ventricle from the right atrium because of the sticky calcified pericardium attached to the right ventricular walls. And so I've summarized these points here. The rapid Y descent occurs from rapid filling of the right ventricle, followed by an abrupt stop in filling. And importantly, this finding, the rapid Y descent, is not seen in tamponade. Shown on this slide is an actual venous pressure tracing from a patient with constrictive pericarditis. This is the A wave, this is the V wave, this is the Y descent right here, and you can see that it's very rapid, prominent, and deep. This is the X descent here. The X descent also gets more prominent in constrictive pericarditis. Now, for your step 1 exam, they're never going to expect you to look at something like this and name the disease process that causes it. It's very hard to interpret actual venous pressure tracings. You just want to be familiar with the classic findings associated with the disorders. And for constrictive pericarditis, the classic findings are rapid and prominent X and Y descents. And remember, the prominent Y descent of constrictive pericarditis is the opposite of what you see in tamponade. And just to make this super clear, I've summarized these things on this table here. So in tamponade, you have a rapid X descent, but you have an absent or flattened Y descent. In constriction, you also have a rapid X descent, but you have a rapid Y descent. And really, these two here are the major ways you're going to distinguish in board questions each of these conditions from one another. And that concludes our module on pericardial diseases.